All right, we're going to get started with the second half. As probably everybody saw, it's raining out there, so we'll try not to keep you too late so you can kind of gently make your way home, and hopefully everybody be safe going home. Anyway, for the second half, Dr. Ablin's going to be speaking about rehabilitation. Is your talk going to be a little more general or specific to the patella luxation patients? More general? Okay, all right. So anyway, I know you know Dr. Ablin, but quick background, she is from Boston and went to that very, very esteemed school, Vassar College, which I've always been really impressed with because I always thought really, really smart people go there. She also went to Tufts. I'm not sure how we end up with so many Tufts people here, but it seemed to work out that way over the last few years. We got all kinds of Tufts people here. She did her internship at AMC in New York City, did her residency at Tufts Angel. If you remember back in the quote-unquote old days, Tufts and Angel were pretty well coupled, so she worked there for, I guess, about 10 years, is that right? And then she was here in Florida for a couple of years and eventually ended up in the Chicago area where she worked until she came down here. So Dr. Ablin did some rehabilitation work in the Chicago area when she was there. We asked her to help us develop our program, which she has done. As I mentioned earlier, she's going to continue to help expand that program. I think a lot of our systems are in place, and I think we're going to be able to start handling more and more patients in regard to rehabilitation. Dr. Ablin is very available by phone if you have any questions in regard to rehabilitation, whether it's going to be questions in regard to managing patients in your practice or ones that you maybe think should be sent here. Please give her a call. I'm sure she'll be able to help you out. Other than that, I'll leave it open to Dr. Ablin. Thank you very much.
Okay, is this volume okay? Okay, good. So we're going to talk about rehabilitation after patella luxation surgery. This talk is more geared to the probably smaller dogs rather than the larger dogs, because those are the ones we tend to see more of. This is a little dog here. This is Sparky, and I just wanted to put this slide up because this is 1 day post-op, and this is what Sparky's doing with his leg. You can see he's not putting it down. So that's the focus of this talk, is how to get Sparky to put his leg down. So we have some goals. We'll talk about 4 goals. The first goal of postoperative rehabilitation for patella luxation surgery is to control inflammation. So how do we treat that? We use cryotherapy immediately postoperatively and then daily thereafter when the inflammation resolves, and particularly after exercise. We can use non-steroidal anti-inflammatory drugs, low-level laser therapy, and acupuncture. And I just wanted to mention it's really important to allow time for the soft tissues to heal prior to starting vigorous rehabilitation therapy. The second goal is to maintain the range of motion and the joint health. We encourage walking for the first 10 to 14 days postoperatively and passive range of motion of the stifle joint for the first 3 to 4 weeks. Flexing and extending the stifle joint speeds joint resurfacing, especially after trochleoplasties like chondroplasties, trochlear wedge recessions, or the block recessions. Probably 30 years ago, there was a study done in rabbits where they did trochleoplasties and they immobilized some stifles and did not immobilize others. And it was found that the cartilage healed much faster in stifles that were not immobilized. We can also consider aquatic walking to strengthen the quadriceps muscle while maintaining motion in the sagittal plane. The dog at right is one of Dr. Brower's post-operative patella luxation surgeries, and you can see this is a big dog, and opposed to small dogs, this dog is bearing weight on its leg on the very first post-operative day. Toy breeds are challenging. We try weight shifting exercises. Some people will tape a syringe cap to the bottom of the non-operated paw to encourage weight bearing on the operated paw, because weight bearing really does increase the health of the joint fluid. The third goal is pain control. We have NSAIDs and maybe other analgesics as needed after surgery. Polysulfated glycosaminoglycans like Adequan, injectable, have mild analgesic effects that last for about 2 days after injection. We also have modalities like acupuncture, low-level laser treatment, TENS, and cryotherapy. And then we decrease the pain management as indicated by our assessment of the patient. This is a pain scale that I use. I'm not sure if all of you are familiar with this, so I'm putting it up here in case it ever pops up in one of your referral records. The pain scale is 0 is no signs of pain during palpation of the affected joint. 1 is signs of mild pain during palpation. 2 is signs of moderate pain during palpation. 3 is severe pain. And 4 is the dog is going to bite you and you can't feel the joint. This is Peepers, and she's our model for some TENS. Our fourth goal is to strengthen the muscle. So initially, activities such as weight shifting to encourage weight bearing. We start with controlled leash walks, limit activities that may put rotational stress on the stifle, and the motion, it's really important that you try to confine it to the sagittal plane. After 2 to 3 weeks, we can focus on increased strength of the hind limb with walking, incline walking, sit to stand exercises, and dancing, as these guys are illustrating. So now I have in your, I think you got a handout or a zip drive of this, and this is a Patella Luxation Rehabilitation protocol that I plagiarized directly from Daryl Millis's and David Levine's book on canine physical therapy. I thought I would just go through this. I think it's a really good illustration of what we would normally use. So phase 1 is the immediate postoperative period to toe touching at the walk. And this is for the first couple of days postoperatively. Our goals during this phase are to minimize the pain, minimize the swelling, minimize edema, and to hopefully maintain range of motion in the stifle joint. There are some therapeutic exercises like slow leash walks, and then this passive range of motion, which it depends on whoever you talk to, how many times a day you do it. There's a nice, let's see if I can project this. This is, it's going to be a YouTube video of how to do passive range of motion. I think that the clients get confused. Sometimes you don't want them to abduct or adduct the stifle. You want them to keep it in a sagittal plane. So there's plenty of links that they can look at to see how to do this correctly. And you can see in this link, she is really extending the stifle. And that's what you want to focus on, the extension. This is one of my favorite devices ever invented. It's called the Game Ready. And this is the box here. This is like a carrying case. And then this red thing opens up, and it's a reservoir where you can put ice and cold water. I don't know if you have these things, but I think this device is just absolutely the best for cryotherapy for our patients postoperatively. And it's a sleeve that goes on the stifle. And these arrows are meant to show that it circulates water. You can set the temperature of this water. We usually use about 38 degrees. You can set the time that this thing is on for. And these arrows are trying to show that you can set the pressure of this cuff. It kind of squeezes and releases. So you can set it for low, moderate, or heavy pressure. And it's great for pain, reducing pain and reducing edema. There's also massage, effleurage as opposed to petrissage. Effleurage is like medium, light stroking. So you want to start from the paw and work your way up the leg. That helps with the edema. You don't want to do heavy, like kneading, like deep tissue massage. It would be too painful. It won't be effective. It will probably cause pain. You can use 10s for pain relief, 15 to 20 minutes once a day to 3 times a day. Cryotherapy like the Game Ready, or cold packs, bags of ice, 15 to 20 minutes. Twice to 3 times a day. Therapeutic laser, once a day, or acupuncture. There's some medications that we use, which we all use, non-steroidals, opioids, calcium channel blockers like gabapentin, NMDA antagonists like amantadine, oral chondroprotective agents like glucosamine products, injectable polysulfide glycosaminoglycans like Adequan if there's osteoarthritis in the patella. And then there's nutraceuticals. I'm not sure if you guys are using these, like duralactin, which is a whey protein, and that inhibits the diapedesis of neutrophils out of the blood vessel walls, and that way helps with inflammation. There's also omega-3 fatty acids. I think the veterinary product is called Well-Actin. I think most people forget that the dose of omega-3 fatty acids for therapeutic levels is 40 milligrams per kilogram. We tend to go a little bit low on that. And then the best sources of omega-3 fatty acids, if you have clients that are buying these things, farm-raised salmon is not a good source, but the best sources are anchovies and those other little fish. Sardines, yeah, right. Those are the best. We'll talk a little bit about NSAIDs. They have anti-prostaglandin effects peripherally, but they're considered centrally acting because of their inhibition of cyclooxygenase within the dorsal horn of the spinal cord. Cyclooxygenase 2, or COX-2 mediated prostaglandin E2 production, contributes to a late onset and prolonged and diffuse phase of central sensitization. So COX-2 specific NSAIDs dampen that central sensitization. And COX-1 sparing NSAIDs, like those pictured at the right, Deramax, Previcox, and Metacam, they have optimal theoretical advantage where there's a concern for platelet aggregation and hemostasis. Next we'll talk. I like it. I haven't used it very much. Dr. Roy has used it, I think. The Galaprant and the, what's the other one? Nocita? Are you using it? Anybody else? You like it? Oh. Mm-hmm. Oh, good. So tramadol, that's good for moderate pain. It falls between a weak analgesic like an NSAID and a strong opioid like morphine or hydromorphone. It's not classified as a true opioid. It has weak affinity for mu receptors, and it inhibits both serotonin and norepinephrine reuptake. Adverse effects for tramadol: sedation, dysphoria, vomiting, diarrhea, inappetence, and the tablets are extremely bitter. So when you're giving this to your client, just remember to tell them you probably need to hide this very well. If their dog is on some sort of tricyclic antidepressant or a monoamine oxidase inhibitor, and I apologize, in your note, I think I wrote MAO instead of MAOI. But if they're on these types of drugs, it's possible to get serotonin syndrome, which would manifest as agitation or confusion, elevated heart rate, dilated pupils, shivering, high fever, and sometimes seizures and unconsciousness. The dose that's quoted in the literature, I think, is 2 to 10 milligrams per kilogram, but I use 3 to 5 milligrams per kilogram 3 times a day. The half-life is really short. So I do tend to dose 3 times a day. And one thing that I found when I was doing this research for this talk is it's not approved for dogs and cats, and I didn't know that. Then we'll talk about gabapentin, and this is an anticonvulsant in people, gamma-aminobutyric acid. It's steroids to work by binding to the alpha-2 and delta-1 subunits of the presynaptic voltage-gated calcium ion channels that are upregulated during central sensitization. The analgesic effect may be proportional to the magnitude of the centralization in the dorsal horn, and it's used for prevention of persistent postoperative pain in people. There's a liquid form for people that contains xylitol, which is hepatotoxic in dogs, so don't encourage your people to get the liquid form for their dogs. It can be compounded. If you're giving an oral antacid, you want to give the gabapentin 2 hours apart because the antacid will interfere with absorption. Doses of gabapentin are 5 to 10 milligrams per kilogram. That's usually, I think, what most people use, BID to TID, and it can cause sedation. The other thing is you shouldn't abruptly discontinue it because you can get rebound pain. I like hydromorphone as an oral opioid. It's not good for chronic maladaptive pain. It's good for acute postoperative pain, so usually for the first 3 or 4 days. And the dose I use is 0.1 milligram per kilogram. I will talk a little bit about acupuncture. So I don't know how many of you are using acupuncture or familiar with it, but with acupuncture we use a needle to induce the changes in the soft tissue. The brain responds to stimulation of manual or electrical needling of the peripheral sensory nerves. It's thought that there's local effects from the needling and neuronal gating, which is, that gate theory of pain where the spinal cord is the gate. So like if you bang your elbow, hit your funny bone, you're going to feel pain. But if you rub this really briskly, you're theoretically shutting the gate and minimizing the pain, and that's what you're doing with the needling. So it's thought that acupuncture may achieve at least 4 theoretic goals: relieve pain secondary to endorphin and serotonin release, accelerate the healing of tissues, activate and control of immune and anti-inflammatory mechanisms, and in people release of physical and emotional stress. And it can also be used to treat trigger points. So trigger points in muscles are like if you're having a spasm and then you put these needles in, that can relieve these spasms or this painful trigger point. Laser therapy. So laser is light amplification by stimulated emission of radiation. The use of light is for therapeutic purposes is known as phototherapy. The types of lasers that we have in veterinary medicine are these low-level lasers or cold lasers. Surgical lasers, which are used for cutting, those cause thermal destruction. And then we have therapeutic lasers, which are kind of in between. And that's what's pictured here. This is a K laser. That's a class 4 laser. This is the laser that we have in this clinic. So laser therapy, it helps to modulate cellular functions through photobiostimulation, which is a non-thermal interaction of monochromatic radiation with a target site. It's thought to modulate mitochondrial respiration, ATP synthesis. It activates respiratory chain enzymes, especially cytochrome C oxidase, oxygen production, DNA production, and reduces cyclooxygenase and prostaglandin E2 production. It's thought to accelerate, it's actually been shown that it accelerates wound healing and joint healing, promotes muscle regeneration. It can be used for acute and chronic pain, to treat acute and chronic edema, and for neurologic conditions. There was recently a paper out within the past couple of years that we discussed in one of our journal clubs where the use of laser was documented to speed the recovery rate of return to ambulation in dogs that were down and back dogs and then went on to have spinal cord surgery or herniated disc surgery. Just a reminder that you need to wear appropriate eyewear because these lasers, if you look at them directly, it can cause retinal damage. E-stim, or electrical stimulation, yes. Right, it's not recommended for over metal implants because of heat production. Also not recommended over tumors because it increases blood flow to that site. Yeah, thanks. So electrical stimulation, we use this to increase muscle strength, for muscle re-education, increase range of motion, correct structural abnormalities in muscles, improve muscle tone, enhance function, for pain control, to accelerate wound healing, to decrease edema, to reduce muscle spasm. And it's been used experimentally to enhance transdermal administration of medication. So TENS is transcutaneous electrical nerve stimulation, used to identify stimulators that modify pain. Neuromuscular electrical stimulation, sorry, I could not get the M to highlight, used for muscle re-education, prevent muscle atrophy, and enhance joint movement. The TENS units works transcutaneously through using surface electrodes to excite nerves, whereas NMES, the electrical current generated by a stimulator, like the pad, that travels through the leads or electrodes placed on the skin to depolarize the motor nerve and produce a skeletal muscle contraction. So when you're doing TENS, it's mainly just for pain, but if you're doing neuromuscular stimulation, you're actually seeing a muscle contraction. It shouldn't be painful, but you'll see it. I think one thing that clients don't like about this is that when you use this, you have to shave the skin and use a conductor gel. Just a cosmetic thing. Now a little bit about aquatic therapy. Has a lot of benefits, improving strength, muscular endurance, cardiorespiratory endurance, range of motion, agility, and psychological well-being, and it can minimize pain. And how does it do that? Because there are these principles that aquatic therapy works through, like relative density. And you can think of relative density as you're comparing the weight of a body against the weight of an equal volume of water. So it's more like specific gravity. So you can think of it as some body that's fat is going to want to float versus a lean body, or a lean dog is going to want to sink. There's also buoyancy, which is the upward thrust of the water against the body that works in our favor with this type of therapy. Hydrostatic pressure, which is the pressure of the water pushing on the body, and this is really good for edema. Then viscosity and resistances. So the water is more viscous than air. There's more resistance to moving through the water. It's harder to move through the water. So if we're exercising in water, it really promotes strength and endurance. And at the same time, if you have a neurologic patient that can't stand very well and you position that patient in the water, there's more viscosity and more resistance. So if they tend to fall or lean over, they're sort of more supported. They don't really fall so quickly. And then the surface tension principle, it's easier, especially in a neurologic patient, because of the water molecules cohesion at the surface. It's very difficult to break the surface, but if you're doing exercises underneath the surface, it's much easier for them. This is an underwater treadmill that it allows for the active range of motion similar to the normal gait. I forgot to mention, it also uses warmth. The temperature of the water is usually in the 80s, and that's very good for cardiovascular stimulation, and also it is not a shock to the patient. They like being in the warm water. And we use it when you need a normal gait pattern for walking or jogging, with increased muscle or cardiovascular demand. So this is a little typical dog that we would use the underwater treadmill for, and you can see they do really well with it. We're using this life vest really to just sort of as a handle for him so he goes in the right direction, but you can use this to increase resistance through the water too and make it harder for them to work. The advantage of the underwater treadmill is that the dogs move in a natural walking or jogging pattern. Joint extension is more complete than swimming, and especially with patella luxations or cranial cruciate ligament injuries, we're really interested in getting the stifle joint to extend. We can adjust the speed of the underwater treadmill. So once the dog has really good endurance, we can have them go faster. We can adjust the level of the water, and this alters the degree of buoyancy. And it also reduces the risk of injury to the joint because of the concussive. There's no real concussive forces, because if you're putting the water at where this dog's level is, like its shoulder, he's roughly about 75% buoyant. So he's, only 25% of his body weight is actually being borne on his joint. The resistance of the movement through the water increases the activity of the muscles during the swing phase of the gait. And as I said, warm water temperatures increase the circulation, the caloric expenditure, and it also allows for increased soft tissue elasticity. And then the hydrostatic pressure exerted by the water on the extremities aids in the reduction of edema. So during this first phase, we really prefer that the patient is in the hospital. But if they're home, they can do some therapeutic exercises like slow leash walks outside and some massage, maybe some cryotherapy like some ice packs or frozen peas. Continue their medications, their NSAIDs and opioids and chondroprotective agents and nutraceuticals. And then when we see them back, we get some outcome measurements with goniometry. This is a goniometer. And we'll use this to measure the angles of flexion and extension of both stifles. So this is a picture of a dog being measured post-operatively. Normal dogs have about 45 degrees of flexion and about 160 to 170 degrees of extension. We'll also do some girth measurements post-operatively, bilateral thigh circumference. We'll also do response to activity and subjective pain level, gait evaluation at the walk, and the patient's weight. It's really important for weight control, especially in these small breed dogs, as they tend to get pretty plump. And then criteria for moving on to the next phase is when the dog is consistently toe touching, has adequate resting analgesia, no swelling, no drainage, and a comfortable range of motion with about 70 to 90 degrees of flexion and 120 to maybe 135 degrees of extension. And this picture is showing, this is a gulag. It has a weight here. So when you do your girth measurement, it's sort of like one of those things that have the little bubble inside. You move that red part into the middle so that you know you're always at the same pressure. Mm-hmm. Pardon? This one is at 70% of the length of the femur. It's found that that's more accurate than if you go at 50%, you have the flank fold that interferes, so that's why people go right above the patella. And then phase 2 is early weight bearing. That's a couple days to a couple of weeks post-operatively. We have the similar goals to control pain, reduce swelling, improve the stifle range of motion, increase the toe touching, and prevent muscle atrophy. There's therapeutic exercises that we would do and encourage the client to do at home. Weight shifting, exercises on a semi-firm surface, leash walking, and then the passive range of motion. And this is just a picture of someone doing some weight shifting. So you'll pick up the non-operated leg, and you can get your clients to do this at home. just pick up the non-operated leg so they're forced to stand on the operated leg. Really easy thing for them to do. And then I also tell them to do heat therapy. If they can possibly do moist heat therapy for 10 minutes, followed by massage, followed by a passive range of motion. Works really well. You can also do TENS. Some people have their own TENS units. We can do TENS here in our little rehab clinic for pain relief or neuromuscular, muscular electrical stimulation for the quadriceps and the hamstring muscles, cryotherapy, or low-level laser therapy. More medications, the same, the NSAIDs, analgesics, the chondroprotective agents, and you might want to do injectable Adequan or some other polysulfated glycosaminoglycan. There's some cheaper ones out there. A home program, the massage, cryotherapy, the non-steroidals, chondroprotective agents, and then really the same outcome measurements as previously is just their pain threshold, their gait evaluation, goniometry, and thigh circumference, and also their weight. And then once they're consistently bearing weight during each stride, we try to move on to the next phase. And when their range of motion, it's usually about 60 to 80 degrees of flexion and about 130 to 150 degrees of extension. This is a product that's an oral chondroprotective agent. Phase 3 is when they're consistently bearing weight at the walk, and your goal is to achieve normal range of motion at the stifle now, and really improve the weight bearing at the walk and at the trot, and also improve the operated limb muscle mass and strength. And this is probably between 2 and 5 weeks post-operatively. So we're still doing slow leash walks, and this is when I'm telling them to add in 5 minutes every week to their walk. Still do the passive range of motion, remember in the sagittal plane, weight shifting exercises, sit to stands. So sit to stands are kind of like doggy squats. I tell them to do that with a treat, and the slower you go down and the slower you get the dog to go up, the more effective it is. Low cavaletti rails. You can also use curbs, serpentine, walking up and down a curb, underwater treadmill, and also land treadmills. Some people have treadmills in their houses and just have to be careful that the dog doesn't go flying off the back. More modalities are heat therapy, the same, heat, massage, then passive range of motion. And if you're going to do cryotherapy, it's really good to do it 15 to 20 minutes if possible. NSAIDs, we're still using those. The home program to really concentrate on the weight loss and continue the passive range of motion, the leash walks, and other modalities that we can use, heat, massage, cryotherapy, in addition to the medications. And then we have same outcome assessments, a gait evaluation, pain, goniometry, thigh circumference. And then when they're consistently weight-bearing at the trot with not very much pain, 40 to 60 degrees of flexion, 150 degrees of extension, we can move on to the next phase. And then I just wanted to just briefly tell you that there's a scale that I was taught to use for lameness. I'm not sure if what everyone else is using. It's just a visual analog scale. So grade 0 is that there's no lameness at all at the walk and the trot. Grade 1 is like a slight lameness, so I would say 25% of the time the dog is lame. Grade 2 is there's an obvious weight-bearing lameness, like maybe 50% of the time the dog is lame. Grade 3 is very severe lameness, so 75% of the time. And grade 4 is the lameness is really non-weight-bearing almost 100% of the time, except when the dog is standing, they'll put the foot down. And 5 is even when the dog is standing, it won't bear weight. Phase 4 of the rehabilitation protocol is probably about 5 to 8 weeks. This is almost the final phase before they return to normal weight bearing. And then we start to get fancy in rehabilitation. We'll start to use these therapeutic balls that we call peanuts. It's really for balancing. We'll still do passive range of motion, sit to stands, cavalettes, and then we have all these other things. I don't know if you can see them in the back, but these are leave poles back here. They're sort of like going in and out. If you don't have these and people are willing to do this at home, if they want to do sort of serpentines around trees or any tight circles, those are very good. And if they do happen to have a treadmill at home, they can incline it and put their dog on it. So the modalities are exactly the same as before: the heat therapy, the electrical stimulation, acupuncture, cryotherapy. We have the same NSAIDs and chondroprotectives. At this point, I don't really give the NSAIDs every day. It's more of on an as-needed basis. And then there's home exercises, still the same things as we mentioned before, but you're just increasing the difficult level. And then this protocol, and you have it in your notes, it will just give you more ideas to use, incorporate into people's regimens at home. So the outcome assessment measures at this point are response to moderate and heavy activity and subjective pain level, still the goniometry, the gait evaluation at the walk and the trot. I usually don't have them gallop in the clinic. It's mainly just a walk and the trot, thigh circumference and their weight. And then when they're really consistently walking and trotting with no pain and no lameness, and they have an absolutely normal range of motion, then we move on to the next level, which is usually at about 8 weeks. And this is when you're going to allow the dog to gallop. Increase the muscle mass should be quite good at this point. They can be doing stairs now, and then up to 30-minute leash walks 2 to 3 times a day, playing with the ball, and dancing. And then I would say at this point, if the lameness does recur, or any time during this protocol that the lameness does recur, because sometimes you'll just overdo it in the rehab clinic and the patient will be sore the next day. But if that does happen, then you want to decrease their activity by half for a first week, and then when you're getting back, just go up 10% per week. That's really all I have to say about the rehab therapy. These are the references that I plagiarized from, and they should be in your handout if you want to look at them. And here's another cool invention that I really like. Are there any questions? Okay, thank you very much.